Good afternoon. My name is Brandy Martinez Trujillo, and today, March 8th, 2019, I will be discussing with you treatment of acute otitis media in pediatric patients 24 months of age as partial fulfillment of the oral comprehensive examination for Colorado State University, Pueblo. In pediatric patients 24 months of age with acute otitis media, is antibiotic treatment more effective compared with watchful waiting on the child's outcome and comfort level within the first 48 to 72 hours of symptoms? What is the significance of this problem, you might be asking? I can explain that to you today. The problem is a majority of antibiotic prescriptions written by providers are for acute otitis media. Half of them are inappropriate, and at least 30% are unnecessary. Empiric broad-spectrum therapy use increases resistance to antibiotics. Frequent use of antibiotics will lead to ineffectiveness of medication. Now, these children in lower levels of poverty, they have an increased chance of recurrent otitis media due to the lack of resources and education. With this being said, it is very likely that they will be overprescribed antibiotics and build a resistance to them, and whatever antibiotics that they are receiving will no longer be effective. For my case study, I chose a 24-month-old Hispanic male patient by the name of MG. He presents to the clinic with his mother. She states he has been pulling at his ears and had a runny nose with some congestion and has been fussy for the past 2 days. Per report from his mother, there has been no fever at home, but he has felt warm. He has never had a problem with ear infections in the past, no recent sick contacts, and is up to date on his immunizations. No current medications are being given, and he has no known drug allergies. MG has one younger sibling, lives at home with his mother and father. He does not attend daycare, and there is no secondhand smoke exposure. MG does meet all developmental milestones for his age. The primary language at home spoken is English. Upon physical examination, MG appears well-nourished and well-hydrated. He does have a runny nose, which his mother did mention upon arrival to the clinic. Upon examination of the ear, there is no edema or erythema noted to the external ear bilaterally. There's some mild redness and bulging of the tympanic membrane in the left ear, but the right ear is normal. MG is afebrile with a tympanic temperature of 98.2 in the office today. For my theory, I chose Kolkaba's theory of comfort. This was developed by Catherine Kolkaba in 1990. She emphasizes on 3 forms of comfort: relief, ease, and transcendence. She defines comfort as an immediate, desirable outcome and product of holistic nursing. She does relate this to 4 global concepts of human being, environment, health, and nursing. She focuses on holistic comfort, which is an immediate experience of being strengthened through having the needs for relief, ease, and transcendence met. As providers, if we follow the structure of comfort, it can help us direct our thinking and our workload to help our patients achieve the best outcome possible. Once they achieve this holistic comfort, the provider's job does become easier and the patient will end up with a better outcome. In MG's case, treating his otalgia will help ease the process of the acute otitis media. Providing holistic comfort along with some appropriate measures for treating notalgia will help the healing process. And we have to emphasize to the mother so that she's able to help assist him in this process of healing. Once pain is eased, then the process of healing will come quicker and easier for MG, as well as his mother and us as healthcare providers. Evidence-based practice. Practice guidelines, according to the American Academy of Pediatrics, would suggest diagnosis is made when a child presents with moderate to severe bulging of the tympanic membrane, fever of 102.2, new onset of otorrhea not due to acute otitis externa, mild bulging of the tympanic membrane, and recurrent onset of ear pain and intense erythema of the tympanic membrane for less than 48 hours. Practice guidelines also suggest that management start with assessing the pain and recommending the appropriate pain reliever. Antibiotics can be deferred in children 24 months of age with mild symptoms. If symptoms persist for 48 to 72 hours, re-examination is recommended, and if antibiotics are deemed necessary, amoxicillin is the first-line antibiotic for that. According to a systemic review by the American Academy of Pediatrics, 437 children presenting with possible acute otitis media, both male and female, between the ages of 2 and 6 years old. It was found that the criteria was not met for antibiotic treatment, and they were still being prescribed antibiotics. Through this study, it was found that watchful waiting was more beneficial and is strongly recommended. Now, they do state that the recommendations do not indicate exclusive course of treatment, and we should consider circumstance such as risk factors. Are they exposed to secondhand smoke exposure? Was there a recent cold or flu? Are they up to date on their immunizations? Things like that are very important when determining whether or not to prescribe antibiotics. In another peer-reviewed study, there was selected evidence-based literature of pediatric patients with acute otitis media and the number of watchful waiting versus antibiotic treatment. It was also found in this study that not all criteria was met when prescribing antibiotics, and they also strongly recommended watchful waiting. They did suggest that more controlled trials would help to determine the benefit of immediate antibiotic treatment versus the watchful waiting period of 48 to 72 hours. However, they did not find that there was any benefit in prescribing antibiotics sooner than 48 hours for those children with otitis media presentation. In a randomized control trial, 100 participants were studied, 47 female, 53 male. 54 were African American, 43 were Caucasian, 1% were Hispanic, and 2 were of other race. The chi-square analysis was used for antibiotics versus watchful waiting with a p-value of 0.437. 92 children were given antibiotics and 8 were told to try watchful waiting. Providers in this study seem to be treating patients based off one finding instead of the criteria of 3. Again, they did strongly suggest watchful waiting in this study as well. Gaps in evidence in clinical practice. There is a lack of documentation in medical records on some of these studies, so it is hard for them to determine how many children had certain criteria and how many didn't. Antibiotics seem to be prescribed to children with non-severe acute otitis media instead of those with severe. In recent studies done, there has not been any indication that antibiotics sooner than 48 to 72 hours is more effective than watchful waiting. But again, there was not enough documentation to deem all of that completely accurate. Providers have been treating based on that one single finding on examination instead of the guideline criteria. APN implications. Upon discussion with MG's mother, it was agreed upon that she continued to monitor MG at home without antibiotic therapy for the next 48 to 72 hours. If he develops a fever of 102.2 or higher, otorrhea, or any other symptom changes, she's to return to the office for reevaluation. She was advised to alternate Tylenol and Motrin as needed for pain. She was advised to give 5.5 of Tylenol every 4 hours and 3.7 milliliters of Motrin every 6 to 8 hours if a fever develops or to treat pain, and was educated that this is a weight-based dose. He did weigh 11.8 kilograms in the office. Within 72 hours, MG returned to the office for reevaluation. He was no longer fussy or pulling at his ears, per mother. Upon reevaluation of MG's ears, the tympanic membranes, there was a decrease in redness and no drainage noted. He was still afebrile. Tympanic temperature was 98.6 in office and did not appear to be in any pain or distress. Per mother, there was no fever development at home, and she was able to appropriately treat his pain. And according to what his mother stated, he was able to get through this process very quickly, and it seems to be back to his normal self. According to the Center for Disease Control and Prevention, assessing and treating pain is key. Tylenol, Motrin, and ear drops, if necessary, are recommended. Determining whether antibiotics are necessary, you have to first determine the likelihood of a bacterial infection being present. Acute otitis media is caused by a bacteria called Streptococcus pneumoniae. It usually presents soon after cold or flu season. And risk factors would be things like secondhand smoke, the patient is not up to date on their immunizations, they were not breastfed, they have a family history of acute otitis media. These are things that we do need to look at when we're determining whether or not to prescribe antibiotics. When you are giving antibiotics, weighing out the benefits versus the risk of therapy is very important. Is the benefit of treating this ear infection better than the risk of the side effects of the antibiotics, such as abdominal cramping and diarrhea? Those are things that you do need to consider as well. Choosing the appropriate agent, dose, route, and duration of the antibiotics is very important. And if you do decide to prescribe antibiotics, make sure that it is done after the 48 to 72 hour observation period. Amoxicillin is first line for children who have not had amoxicillin in the past 30 days. If there has been amoxicillin in the past 30 days, Augmentin would be the next antibiotic of choice. If there is a penicillin allergy, there are other options such as cefdinir, ceftriaxone, cipodoximine, and cefuroxime. Quality improvement. Be thorough in examination. Determine treatment based on education and poverty level, along with risk factors, and always practice stewardship when prescribing antibiotics. We have to determine all factors when we are deciding whether or not to prescribe antibiotics. Identifying all specific criteria prior to diagnosis and treatment of acute otitis media. Use your best clinical judgment. That is what is suggested and best practice. Following up with the patient via phone call or scheduling an appointment. That is very important. Even making a phone call, asking if the patient is feeling better. Have they developed a fever? Are there any new symptoms? That is very important, and it helps the parent in many cases because sometimes they are afraid to contact the office or they don't want to feel like a bother. We have to make sure that we let them know that we do care and that we are checking up on them and that we want to make sure that their child is getting the appropriate care necessary. If they do have a scheduled appointment, make sure to thoroughly examine them again. Make sure that they are feeling better, back to their normal selves. Practicing watchful waiting. It is very important to practice watchful waiting. Some prescribers will do what is called delayed prescribing according to the CDC, which a prescription will be written and the parent will be told to fill the prescription if the patient does not improve within the next 48 to 72 hours and they develop new symptoms. You have to be careful with this because unless you are properly educating the family on this, they may fill the prescription and start the antibiotics anyway. That is why practicing watchful waiting and reevaluating the patient yourself is better practice and highly recommended. Appropriate pain management is very important because with pain management comes a quicker healing process and better outcome for the patient. Further evaluation and collaboration with specialists such as ear, nose, and throat doctors if the problem does continue and the patient does not seem to be improving or they have recurrent ear infections. According to evidence, considering watchful waiting for 48 to 72 hours in pediatric patients 24 months of age with acute otitis media prior to the decision of prescribing antibiotics does have an impact on the outcome. Once pain management is addressed and the appropriate level of comfort is reached, the child will have a better outcome overall. By following these recommendations and guidelines by the American Academy of Pediatrics and the CDC, unnecessary antibiotic treatment is less likely. And always remember, above all else, practice with compassion and respect for the dignity, worth, and uniqueness of each patient. Do not restrict that by any considerations of social or economic status, personal attributes, anything like that. We have to treat all our patients with the same dignity and respect that we would expect our family and children to be treated with. Here's a list of references I used to guide me in my research. I want to thank you for allowing me the time to educate you on this topic. I hope you have a wonderful afternoon, and God bless.